Welcome to Psych Talk for primary care providers, where our esteemed faculty members will provide you with invaluable insights to seamlessly integrate into your daily practice. Today, we will have Dr. Michael Lang talk about somatic symptom disorders and how best to manage these patients.
Hello, everyone. I'm Mike Lang. I'm an internist psychiatrist from East Carolina University School of Medicine. And today I am talking about two of the more common somatic symptom disorders. The reason why I'm bringing this up for you is this is something that winds up happening a lot to primary care doctors because they're exquisitely difficult patients. They require a lot of resources, and they can be difficult to manage because you cannot enlist psychiatric help. One of the core features of their diagnostic problem is that they do not believe anything psychiatric can be going on. And so less than 2% of them will actually follow up with a psychiatric referral. What winds up happening more often is they come back to you with continued symptoms. So it would be important for you to kind of get an idea of how to manage these people, since they tend to provoke dread when you see them on your schedule. So in 2013, a lot of the somatic symptom disorder criteria were reimagined and refined when we were moving from DSM-4 to DSM-5. And the reason for that is the diagnostic criteria were muddy. Many of the disorders shared the same diagnostic criteria, so it was hard to parcel them out and make sure that you had a firm diagnosis. Because in a grand sense, the management is the same, but there are some subtleties. So the first one I'll talk about is somatic symptom disorder, which replaced somatization disorder. And the reason it did was that no one could ever make the diagnosis of somatization disorder because it took years to accumulate these symptoms in multiple body counts. So now with somatic symptom disorder, which is more refined, it is the state of being symptomatic that matters. They will have non-specific vague symptoms. I might have chest pain. I might have abdominal discomfort. I might have pelvic pain. I might have a headache. And they feel that something is wrong. They may not necessarily know what that is, but they're coming to you to find out what that is. And you have done a medical workup, perhaps very thorough, and nothing has come back. So what you will find with these patients is it is the state of being symptomatic that counts. They have thoughts of what could be going on. They have a persistent amount of anxiety relative to what could be going on. And they devote a lot of energy into trying to manage those symptoms, which impacts their level of function and their quality of life. An important caveat to this. Previously, it was the fact that it could not be medically explained that counts. And that has been removed and discounted to a good degree because medically unexplained only matters in the context of what we know today. Previously, from a historical sense, pediatric epilepsy was felt to be a behavioral disorder until we discovered EEGs. And so people used to get spanked for their seizures, and now we know that they were actually having a medical problem. So in the 1930s, that was medically unexplained. It is not medically unexplained now. And so it is the state of being symptomatic that counts. So what do you do with these folks? Well, you can try sending them to a psychiatrist, but the likelihood that they will follow up is less than 2%. And so what I counsel people to do in this, or if it's illness anxiety disorder, or if it's functional neurological disorder, the previous conversion disorder, you lean into these patients rather than leaning away from them. They actually need more visits rather than less. And you have to always focus on what you objectively see, not necessarily what the patient is symptomatically complaining of. So always use your eyes, touch them, do a firm physical exam, listen to what they have to say, because 70% of your treatment plan is in your report. You don't say it's all in your mind. You say, I don't see anything objective going on, and I'll reevaluate you in 2 to 3 months, and we will see again if anything develops. Then the patient knows, A, they've been heard, B, you were listening and you were following up on their complaints, and C, you did not find anything to be concerning. That will only reassure them, but for so long. But with repeated visits, you A, establish the rapport, B, you're continually looking to see if anything is actually developing, and C, you prevent inappropriate care. So whether it is somatic symptom disorder, where they come with vague symptoms, or illness anxiety disorder, where they come with a diagnosis, doc, I've got HIV, I know I've got HIV, and I need you to find it so that we can do something about it. Both of those require frequent visits. And you will find that frequent visits decreases your phone calls, it will decrease your emergency room visits, and it will decrease your accidental hospitalizations where these patients get exposed to MRIs and lumbar punctures and blood cultures and all manner of things that, quite frankly, aren't necessary. So steady communication, frequency of visits, and always keeping an objective eye, because even hypochondriacs get sick, will prevent inappropriate care. And thank you.